is that scale only benefiting United Health Group, or is it benefiting society at large, the end consumer?
Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab U Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Hey everybody, Rafi here from Rehab U Practice Solutions. And if you run a healthcare business, a practice, or a startup, and you're looking to differentiate yourself from your competitors, gain market share, and actually drive qualified leads into sales conversations, then I'd love to have a conversation with you. Check out what we do at rehabupracticesolutions.com. I'm sure there's a button there to book a call. We can chit-chat about what's going on in your business and if there's some way I can help. So this week, we are diving into the topic of scale in healthcare and what that means for the little guy. So I run a small private practice in addition to doing everything that I do here. And this topic comes up a lot, specifically when we start talking about the big payers. You know, we'll say UHC because they're the biggest one that get all the flack, but it's really all the big healthcare insurance companies. There's just a downward pricing pressure that all of the providers, the people delivering the service, are feeling every single year when they do their budgets. I mean, Medicare does it every year when they come out and they say they're going to do a Medicare cut. UHC does it when they cap their daily rate. Other companies and payers do it when they go into prior authorization and determinations and limiting the amount of services that are covered. So I want to talk a little bit about that. I want to talk a little bit about kind of the way we should look at this as practice owners, as business owners in the healthcare space, just kind of get some context around what's going on, but then also maybe a framework for thinking about what this means for healthcare business, the positives for the consumer, et cetera, et cetera. So this all started with a conversation that I had with Paul Singh a while back on this idea of people wanting to blame somebody for business not going well, right? And sure, there are things that are out of our control, but the one that gets thrown under the bus, like I said, a lot is the payers, especially on the provider side. The payers are the bad guys. You know, we're fighting against the man. These payers are trying to push us down. So one of the things that I said in that conversation, and I'll link to that video down here because we made a clip out of it that is circling on or making the circulation on YouTube and LinkedIn and all that. But that part of it, we need to understand that it's a function of two things. One, it's a function of the way we pay and reimburse, quote unquote, for healthcare services here in the US, which is one of the main reasons for the downward price pressure. We'll talk about that. But then also is just the size and the scale of the healthcare sector. So one of the things that I said in that conversation with Paul was that I believe a lot of what you're seeing, these big conglomerates that are coming into healthcare and they're buying practices and they're offering health insurance plans and they're doing pre-authorization and they're managing the data and revenue cycle management. By nature of the fact that healthcare is so large as a sector, there's just a lot of money to be made. It is no surprise that a bunch of big companies are coming into the space, or companies that started out small that got some success are growing as much as they are. It's more or less a feature of the system and not so much a bug of it. And what I mean by that is that by nature of the fact that there's so much money circulating and changing hands in and around healthcare, it is only natural that there are going to be companies that become huge. They might be proportionally, they might have a small sliver of maybe a specific, maybe it's musculoskeletal, or maybe it's physical therapy, or maybe it's like specialty in renal care or oncology. All of those might be small little slivers, you know, a percent here, a couple percents there of the whole healthcare market. But because healthcare is huge, billions and billions and billions of dollars, even those small slivers yield company, to create companies that are huge and have a lot of leverage when it comes to scale, when it comes to regulatory lobbying and the like. So there's that piece, that healthcare itself is just big. And when you get a sector or an industry that's big, it means that the dominant players, by nature of the size of the market, are big. So that's something we have to contend with. The other thing we have to contend with is, like, is it all bad, is the question mark. So on the provider side, when we're dealing with a payer like United Healthcare, and they're capping the daily rate at, I know in some places, somebody told me on Facebook the other day, it was like $35 a day or something like that. I know in our area, United Healthcare was reimbursing $55 a day, which is not sustainable. It's not financially doable for a small independent private practice to treat for physical therapy, for example. Let's say you're paying the therapist $50 an hour. You can't treat a patient for an hour and get paid $55. That's just, you're going to go out of business doing that. So there's a lot of negativity that gets thrown in that area, like, oh, UHC is squeezing providers and it's causing all kinds of negative externalities to the private practice owners that are out there trying to treat patients and do good and serve the community. And there might be something to it. I go back to the levers, but we'll talk about that in a minute. The question I have, though, is that necessarily a net negative to society? And what I mean by that is, I'm listening right now to Poor Charlie's Almanac on Audible. It's a series of Charlie Munger's talks. Charlie Munger was the late business partner of Warren Buffett at Berkshire Hathaway. He gave a bunch of talks. I think one that I was listening to was like from 1986, one from 1990 something. So commencement speeches and things like that, where people were asking him about business wisdom and the like. And a lot of what he said is just as relevant today as it was back then. And he talks a little bit about scale in one of his talks, the benefits of scale. And I'm just going to read directly from the transcript and I'll kind of talk about it. So he said, let's go through a list, albeit an incomplete one, of possible advantages of scale. Some come from simple geometry. So for example, if you're building a great spherical tank, obviously as you build bigger, the amount of steel you use on the surface goes up at a square and the cubic volume goes up with the cube. So as you increase the dimension, you can hold a lot more volume per unit area of steel. So that's just an example of growth by scale, like the power and advantages of scale. And he said there's other kinds of things where, like, the simple reality just gives you the advantage of scale. For example, he talks about TV advertising when it first came out. When TV advertising first arrived, it was called talking colored pictures, first came into the living room. It was an unbelievably powerful thing. And in the early days, we had 3 networks that had, let's say, 90% of the audience. So if you were Procter & Gamble, for example, you could afford to use that new method of advertising. You could afford it, 1, because it was very expensive, but 2, because you knew you had a captive audience. And you were selling a ton of like cans and bottles and soaps and whatever. Some little guy, a small mom and pop shop, could not afford to buy advertising on TV. So they, for all intents and purposes, they couldn't use it. So in effect, if you didn't have the big volume, you couldn't use network TV advertising, which was at the time the most effective technique. So again, like, you're getting a lot of advantages. The companies themselves are getting a lot of advantages from scale. Now the question is, are those advantages only going to the company? So in this case, let's pick on United Healthcare since I started out with them. United Healthcare has a lot of scale. They have millions and millions in contracts with Medicare Advantage plans, for example, with hospitals. They own hospital groups and physician groups and practices, Optum Physical Health. They're doing a lot of the credentialing. So they have a lot in the way of scale within the healthcare system. There's when Change Healthcare went down, which was the clearinghouse that's owned by Optum or United Health Group. I don't know. There's so many conglomerates. It's all United Health Group at the end of the day. When it went down, I think somebody said early on, this was early this year, that I think at one point in time, Change Healthcare was at the time or in and around the time where the breach happened, was processing somewhere in the neighborhood of 48 to 52% of all the healthcare claims in the United States. Like, that is massive, the amount of money that is flowing through that, but the amount of impact that United Healthcare had on the entire healthcare market. So they undoubtedly had scale. The question is that scale only benefiting United Health Group, or is it benefiting society at large, the end consumer? Because who's the end consumer of healthcare services? Well, one could argue that it's the provider, right? The provider's on the receiving end, sometimes of working with maybe a payer like United Health Group or United UHC, or the insurance branch of that, or the providers delivering care that are getting paid by UHC. And then ultimately, when we think about the end user or the end recipient of healthcare services, is the patient, right? So the question is the patient materially damaged by the fact that the physical therapist, for example, is getting paid a $55 daily rate for their visit? I would argue, and this might be an unpopular opinion here, but I would argue that probably society is experiencing a net benefit because of that, insofar as like cost reduction and access to care, right? You could make the argument that, well, people are leaving, a lot of providers are leaving UHC's network, and we see it all the time every year when negotiations for contracts come up, that this hospital is going to drop UHC, or this hospital is going to drop this payer or that payer or Humana or whatever. And it's really just a lever that they're pulling to get to the negotiation table to increase that kind of push-pull between expense and savings. But ultimately, I think that benefits the patient, because the patient is on the hook ultimately for the cost of the care they're going to be receiving. And when you have an organization like United Healthcare driving the cost down, the patient's a net beneficiary of that. Now, it does mean that there are some things that you need to consider as a business owner in healthcare, because it means that the savings that you're purporting to make, or the savings that are purportedly coming into healthcare because of some actions like this, are going to be detrimental to the providers unless we change the way we're delivering services, right? Which we can talk about in a minute. The main reason for that, and I alluded to it earlier, is this idea of how we pay for healthcare in the United States. So in the United States, we're very much fee for service, which means, as my dental friends say, if you're not drilling, you're not billing. So there's an incentive on the part of the providers to see patients for, as without like sounding nefarious, like this is not like a conscious thing, but there is an incentive to maximize billable productivity, which means we want to see the patient for the minimum number of minutes necessary to bill the maximum number of units. For example, take the 8-minute rule. It is much more advantageous, and I remember getting told this as an early OT when I was just starting out. And it's much more advantageous to see a patient for 53 minutes than it is for 60 minutes. Why? Because at 53 minutes, you bump into the next realm of being able to bill a fourth timed unit to a health insurance company. All that time from 53 minutes to 60 minutes is the same, right? You're not getting paid any more money for each additional minute. But once you cross from, like, say, a 67-minute, I can't remember what it goes to, like 38 to 53 is, or 52 is 3 units. So again, if you're going to bill 3 units, you want to fall in that 38. You want to fall close towards that 40-minute mark. Because if not, you're giving somebody 12 extra minutes of time that you're not going to get paid any extra for. So there's this incentive on the part of the providers to bill just enough, or to see a patient just enough to bill the next level of unit, or to bill an additional unit, arguably without adding any additional value to the patient or to the outcomes. So that's just the nature of being in a fee-for-service model, where you are getting paid for the time you're spent with the patient. So what that means is that there's this incentive. Providers are trying to bill as much as they can and see as little as possible. And then on the payer side, the only lever that they have to maintain financial solubility is to decrease the cost, right? How much they're paying out. When it comes to that, the only real levers they have to pull to decrease their cost is to either pay you less as the provider, or to decrease the amount of services they're going to cover or pay for the beneficiary. So they're walking this tightrope too of trying to make sure their end user, their customers are happy, and their providers they have enough providers in the network to make this model work for them. But those are the only real two levers they have to pull to affect change, because if everybody keeps using the service and they're paying all the providers as much as the providers want to get paid, pretty soon they're underwater and they're not going to be able to make money, which means nobody's going to get covered, and it's a big mess. So again, I would argue that it's not like none of this is nefarious on United Healthcare's part. They're just trying to run a good business. So we need to understand that as providers. Part of that means that maybe we need to explore different revenue models or ways that we pay for healthcare in the United States. Maybe it's fee for service, maybe it's global service delivery fees, or something of that nature. But at the time of this recording, the vast majority of payers are involved in this fee for service model, where you've got you're getting paid, the providers are getting paid for the number of units that they bill. And that creates certain incentives, and that means that the levers that the payers have to pull are only so many, right? Only those two. One of the things that Charlie Munger mentioned in one of those talks, which I thought was pretty interesting, was the idea of understanding where those savings go. Because at the end of the day, he was talking about Berkshire Hathaway being in the textile business. And there was some loom that got created, and it was supposed to increase the productivity by whatever, it was supposed to double or triple the amount of textiles that could be produced in the same amount of time. And someone came and told that to Charlie and Warren Buffett, and Warren Buffett said, well, I hope that's not the case, because if it is, we're getting out of the textile business. And what he meant by that was they were going to shut the business down. And part of that was he understood that the nature of a commodity business, whenever there's an efficiency gain or some kind of productivity gain that yields real savings in the commodity space, a lot of times that savings is transferred directly to the buyer, to the end user, to the customer. It's not so much saved or transferred to the company. So in that sense, you could be, and Warren Buffett saw this in the textile industry, he was going to have to buy this new loom, which was going to cost so much capital investment to buy this new expensive piece of equipment, and they really weren't going to experience any net benefit from that. The consumer would, but Berkshire would not have gotten any improved profitability from that. It wouldn't have increased their margin. Maybe they would have been able to sell more, but again, in their minds, that was going to be a misuse of capital to take it and invest it in a business that was already running low margins, and that was going to be capital intensive to run. Like, why would they dump more capital into this to get the same return when they could take that capital and put it in something that's not a commoditized business, where the gains and the efficiencies end up, some of those savings get passed through to consumer, but the majority of them stay with the business. So understanding that savings flow is important. So in healthcare, for example, United Healthcare is out there and they're contracting with all kinds of people, and there's going to be a lot of patient volume. And in big like chain health systems and physical therapy clinics and chains and all that, like they are operating at scale. So they are looking at things like, okay, it doesn't matter if we take $5 less per day per patient or something like that, because we're seeing so many. And they're in the commodity business. They're selling a commodity, right? So if you're in the commodity business, you almost have to go to scale, because that's the only way you're going to be able to stay financially solvent. And you have to understand that every cost saving or every savings that's realized is really going to be passed on through to the consumer, and you're not going to capture any of that as the business owner. Maybe you'll capture more, increase your bottom line purely on the fact of increased volume and increased productive capacity, but it's not necessarily going to be increasing your margin or the actual profitability of the business. So it was just an interesting insight hearing Charlie Munger talk about this, because they were in the business of trying to get outsized returns. They didn't want just 6, 7, 8% profit every year. They were looking at double digits, not triple digits, but double digits as high as they could. They wanted to outperform the market. Otherwise, there's no point in them being in business. There's no point in them getting and earning money. So or not earning money, but taking that capital and investing it into businesses versus just buying an index fund, right? Indexing to the stock market. And I think there's a lesson there to be learned within healthcare, specifically on the private practice side. Like, are we in the commodity business? Because if that's the case, we need to begin working on efficiencies. We need to begin scaling. We need to be growing to the point where we have some of those benefits that Charlie Munger talks about in scale. If we're not, if we're going to be very specialized and very niche, then the business model changes a little bit. Then we're not so much worried about whether or not United Healthcare only pays $50 a visit or $55 a visit or $35 a visit, because we're probably not going to be in network with them, and we're probably going to be selling something that is a premium service. But what I often find in talking with other physical therapists, other practice owners, is that we end up straddling this fence, right? Like, we say we're offering something of value and that's not a commodity, but at the same time we want to do business in the same way that, these commoditized healthcare companies are doing their business. And you can't have it both ways. You can't say I provide something of value and of exceptional value that's not a commodity, and then run a business that is based off of volume and productivity, right? So the question is, how do we kind of do that in our minds? How do we make that switch? And in my mind, it comes down to this. It really comes down to exploring alternative payment models, but then also looking at what the customer wants and what the payer wants, and trying to blend the two so that it can be profitable. For example, our practice is it's a hybrid practice, which means some of our contracts are with insurance companies. We do accept Medicare, and then some of them are also with payers, but we're involved in more value-based reimbursement models. And then we see direct patients, like direct access patients that pay us cash, self-pay patients for the services we deliver. And with all of those, we manage them in a way that we're looking at what the patient wants or the customer wants and what the payer wants, and blending the two so that we can make it profitable. For example, there's a workman's comp company that is kind of like a third-party, like case management company that we work with, and they pay very low per day. I think it's like $65, $75 a day is the max, their daily max. What we have discovered, though, is that the patients that we see through this workman's comp, and they do bring us a lot of our workman's comp patients come through this company. What we've gotten to the point of understanding is like, well, these patients don't need an hour of treatment. So if I was just falling back on this whole, we're building this thing to scale and every patient's going to be going to get an hour slot, we're going to bill 4 units, we're going to go in this manner, or even 3 units, we're going to lose money, right? You can't take that business model and employ it on something like this, a payer like this, a payer relationship, and expect to make money. So what we do is these patients come in, it's a 1 to 2 unit treatment. So they're coming in here for somewhere in the neighborhood of 15 to 30 minutes. They're getting exactly what they need. It's the valuable service that they need, the insights they need. Maybe it's knowledge translation, maybe it's training, maybe it's progressing their home program, working on whatever kind of simulated work tasks they have, and then sending them on their way to do the stuff at home. And that is profitable for us because we're getting enough patients from them to make the volume work, but then we're not seeing them so long that we're losing money on those visits. And I think a lot of times, I was just having a conversation with another therapist, another practice owner, who said, well, we just can't do it because our model is hour-long sessions. And that's true. Like if your business is an hour-long session and you have a payer that's paying you $35 an hour, you're not going to be able to keep your doors open. So then your choice is, don't be in network with them, with that payer, and charge the patients cash, which means you're going to lose on some volume. You're going to lose some patients that are going to go to a provider that's in network. That's just part of healthcare. And part of that is because healthcare is seen very largely as a commodity. I know that what we do as providers and clinicians, we'd like to think we're not commoditized, that we're delivering something of high value and high quality. In a lot of cases, we are. Specialized knowledge, specialized skills. The problem is we're trying to fit it into a business model of a commodity. So we have to understand, like, if we are going to take those contracts, we're not falling into this, if we want to maintain profitability, especially in like the physical therapy space, you can't fall into this commodity boom, 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 boom. You need to start being creative about what does the patient actually need? What does the payer want? How do I make that work? And I'm still trying to figure this out in my own business as well. Like we're in the middle of doing this right now. We've got a payer that gives us a lump sum for their patients. So we do the eval, they do a determination. They say, we're going to give you $800. That's as much as we're going to give you. You can see the patient as long or as little, as many times or as few times as you want to. And we're managing that now with, hybrid care. We're doing some telehealth. We're doing some remote therapeutic monitoring. We're limiting the amount of time the patient needs to be in the clinic. But we're trying to maximize the outcomes we're able to provide that patient. And part of that is having the flexibility of knowing we already got paid. So it doesn't matter. It doesn't matter what we do. Like we don't have to worry about billing this code and this code together and then it getting denied because we've already been paid for it, right? So there's some freedom in that, and that has helped us a good bit. But I do think there's some thought that we should be having and putting around this idea of, one, where does the savings go in healthcare? And then two, how do we decide whether or not we're going to move towards like this commoditization where it's just high volume, maybe arguably, decent quality, or like not commoditized at all, very specialized, very expensive. Because you can't have a healthcare system that's made up of entirely one or entirely the other, and you can't have a business that's doing both, right? So it's worth thinking about and worth exploring. I think I'm going to do a little bit more reading into this area some and kind of come back with some more thoughts. That's just what I'm thinking. After listening to this talk by Charlie Munger and then hearing some of the recent and reading some of the threads on the owners forums and on LinkedIn from other providers complaining about the downward pricing pressure in healthcare, part of me, my knee-jerk reaction is like, yeah, it is bad as a business owner. I don't want to be getting paid less for the work that I'm already doing, but at the same time, there's got to be opportunity there, and that opportunity has to be in exploring different ways of delivering services that people need, right? In ways that are profitable and that there is a delta to be capitalized on versus like this high volume, low margin work, which is just a tough business to be in, right? Anyways, those are my thoughts on that so far. I'm sure they're not as coherent as I would like them to be, but it's something I've been thinking about the last few days since having this talk with Paul and then kind of seeing some of the back and forth on the interwebs about downward pricing pressure in healthcare and what does it mean. I know there are interesting companies out there that are doing things that are ancillary to like skilled healthcare services, but that are making a lot of money doing it and they're filling a need in the market. And I don't see any reason why a healthcare provider can't tap into some of that as well. So anyways, that's all I've got for today. If you like the show, share it with somebody you think would find it interesting. I always tell people, at the very early on when I first started the podcast, I would follow the metrics, who's liking, who's sharing, the ratings and all that. Now I'm worried about impact. I want people to let's push a conversation into the space. So share the show with somebody you think would find it interesting and insightful. And if you have thoughts on the topic, specifically around this big healthcare and scaling and what we do to ensure positive patient experiences, good clinical outcomes, and financial sustainability for the providers, shoot me an email, info@rehabupracticesolutions.com. If you're doing any work in the space and you want to talk about it, shoot me an email. We can get you on the show and talk about it, have a live discussion about the positives and benefits of like a commoditized healthcare system versus a specialized niche healthcare system. So anyways, if you want to find the book, Better Outcomes, A Guide to Humanizing Healthcare, you can read more about it, watch a couple video clips, maybe even listen to the first chapter for free at book.betteroutcomes.show. If you want to hire me to speak at one of your conferences or train at an organization, go to speaking.rafisalazar.com. And if you want me to work with you on a go-to-market strategy to drive qualified healthcare leads into your sales process, you can learn more about that at rehabupracticesolutions.com or positioning.rehabupracticesolutions.com. Until the next time, be safe, be healthy,
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabuppracticesolutions.com. We'll catch you on the next episode.
Thanks for listening to another episode of the Better Outcomes Show with Rafi Salazar. This episode was brought to you by Strata PT. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how their EMR and RCM works, head over to stratapt.com to book a demo.